Thank you. Now I would like to invite Dr. Taruna. Dr. Taruna?
Hello. Good morning,
From
ma'am.
ERAS, Lucknow Medical College and Hospital in India. Dr. Taruna?
Yes.
You have the floor.
Very good morning, ma'am. I'm present. Okay.
Please, can you share your screen?
Sure, ma'am. तो करो. Hello.
Hello?
Hello. Ma'am, there is someone who has already joined. That's why I'm unable to share actually. Hello.
Hello?
Hello.
Dr. Taruna?
Yes, ma'am. I'm present.
Can you share your screen with us?
Somebody has shared already, I think.
Okay. Because we are not seeing it. Can somebody help us?
Hello.
Hello?
Hello, ma'am. I'm present, but I see somebody else has shared my screen, I think. While the other participant is already sharing, ma'am.
We can see it. Hello, Jessica? Dr. Cruz? Dr. Cruz? Dr. Cruz?
Ma'am,
Yes.
somebody is already sharing the screen. That is why I'm unable to share.
Okay, I'm sending a message. It's Dr. Cruz.
Okay. Good
You
morning.
can try now.
Okay, thank you. Good morning, ma'am. first. Good morning, everyone in Dubai, and a big hello to everyone around the world. Whoever has joined the webinar, what a wonderful session we are having. And I'm very thankful to the organizers for giving me this opportunity to present my work on this such a huge platform, madam. I'm really, really grateful. Myself, Dr. Taruna Singh from ERAS Lucknow Medical College, Lucknow, India. And my topic for today is optimum radiation fractionation schedule in advanced cancer cervix, a study from low source North Indian Cancer Center. Ma'am, am I audible clearly? Am I audible clearly, ma'am? Am I audible clearly, ma'am? Am I audible clearly, ma'am? I can't hear you, ma'am.
Okay. I have to unmute my microphone.
Okay.
It's clear.
I can hear you, ma'am. Am I audible clearly?
Yes, you can go on.
Thank you so much, ma'am. So regarding the introduction of my work, which I've already told you in my first slide, that is optimum radiation fractionation schedule in advanced cancer cervix, a study from low resource North Indian Cancer Center. Regarding the introduction, a quick, that is cervical carcinoma is the most commonly occurring lethal cancer among women worldwide. And you know, it's very prevalent in India, which is a low socioeconomic status country. And women suffer from the locally advanced cervical cancer when they present most of the times, and external beam radiotherapy with concurrent weekly platinum-based radiosensitizing chemotherapy and brachytherapy, they are considered to be the finest treatment available for such ailment. Then a few words more regarding the introduction only. That is, India is actually, the OPDs are also overburdened with the number of cancer cases, especially the cervical carcinomas. And there are so much of treatment constraints, other facilities constraints, and global burden of cervical carcinoma has ever been increasing. Although now it has been taken over by the breast carcinomas as the living standards have changed, and people are more aware of the possession factors. So India accounts for 17% of the cancer deaths among women during their reproductive age group, and cervical carcinoma stands to be an important and significant cause among all. And to continue regarding the introduction only, according to the FIGO, we all know it is an International Federation of Gynecologists and Obstetricians. They're providing the things that the combination of surgery and radiotherapy, it escalates the morbidity and should be avoided. But what to do? The advanced cases, they cannot be taken care of by surgery alone. They have to be combined with the other modalities as well. And for the local control as well as for the ease of survival as such, you have to have a multimodality approach for the treatment of cervical carcinoma. Overall treatment should not exceed 56 days as been established by people of great research as far as the radiation is concerned, including intracavitary brachytherapy. And we all know squamous cell carcinoma, that I will be talking in the later slides. What are the most common histopathological types? And quickly have a then there are certain guidelines, of course, we all know. As far as the radiation is concerned, radiation treatment particularly is concerned, there are various guidelines which are quite relevant with regard to the Western world, but they cannot be followed as such or in totality in our country like India, which is still socially and economically low economic status country. So there are certain modifications. We are also having our own brachytherapy and the radiation committee, and especially with regard to the brachytherapy guidelines committee, which is to be followed on all the centers all over India, right? Then The dose distribution will be now. Before coming on to all this, that I would like to first present my aim. What is the aim of my work done over? The purpose of this study is to assess the tumor response following high dose rate brachytherapy preceded by external beam radiotherapy and identify optimum radiation fractionation schedule for the better response with tolerable radiation toxicity. And accordingly, I have given a gist regarding the introduction as such. Now, quickly coming on to the materials and the methods. How I was pursuing all this work. The study was conducted in patients attending the outpatient department of radiotherapy at North Indian Hospital. 91 patients diagnosed with carcinoma of uterine cervix were screened for the inclusion in the study. All patients underwent complete evaluation by history taking, gynecological examination, and systemic examination. Certain symptoms such as vaginal bleeding and discharge, pain in lower abdomen, backache, difficulty in micturition and defecation were also noted. All patients underwent complete evaluation by history taking, and then the complete blood count, liver function test, renal function test, chest diagrams and ultrasound, pelvis and abdomen were also performed. MRI pelvis was done in few cases. Patients were categorized according to the stages on the basis of FIGO staging system, which is followed worldwide. And the study was done only after the ethical clearance from our committee. Was obtained from the institutional ethical committee. Now the criteria that we have took, inclusion exclusion criteria. Histopathologically confirmed carcinoma of uterine cervix cases, patients with any kind of pelvic infection, fibroid, ascites, and other concurrent systemic illnesses. FIGO staging 2A, 2B, that is the bulky one, the 3B, pregnant women or lactating mothers, they were excluded. Kornofsky score was taken more than 70. Patients who has given approval and informed consent were recruited. Now the treatment allocation. All enrolled patients in this study after histopathological confirmation, they were marked on their surfaces and they were treated initially by teletherapy using a field size of 15 by 15 centimeter. And they were treated by APPA fields by the telecobalt unit. I have told you in the early, in the first slide only, a study from low economic resource center. Then that is why I'm talking about external radiation being given by the telecobalt unit, which is becoming almost obsolete now, but still it is of very, very importance for places where there are so much of economic constraints for the linear accelerators to fully come into play. Those patients who had separation of more than 20 centimeter, that means obese patients, they were treated by 4-field Brock's technique, 2 orthogonal X-ray pelvis, CT-assisted scanograms and slices, and the plateau treatment planning system was utilized. After the completion of the external beam radiotherapy, the patients were evaluated for regression of the tumor and given symptomatic treatment if required. That means relevant to the reactions occurring out of radiation treatment. Procedure was done under strict aseptic conditions, under conscious sedation. The patient was put in lithotomy position and examined without anesthesia for reassessment. The part was prepared, followed by short anesthesia, that is ketamine. An assessment of the fornices was done to decide upon the size of the ovoids to be used, whether half, small, medium, and large. Then the length of the uterus was assessed with a uterine sound, and the treatment was done for the uterine length more than, that is 4 centimeter to 6 centimeter. The Fletcher suit applicator was used, and adequate packing away of rectum and bladder was done to reduce the overall reaction to these critical organs. And somewhere a tungsten retractor was also used to push away the bladder and the rectum. Then the patient was shifted to the HDR treatment, where the catheters were connected, and individualized treatment was received by the microselectron after loading system. Treatment protocol, that is combined external beam radiotherapy and high dose brachytherapy, was given in stages 2A, that is FIGO stages 2A, 2B, and 3B, and 1B, which was only more than 3 centimeters. External beam radiotherapy along with intracavitary radiotherapy was given like this. Once the external beam radiotherapy was completed for the gross disease, it was followed for intracavitary high dose rate microselectron HDR microselectron application at a gap of 2 to 3 weeks after completion of external beam radiotherapy. Cases of cancer uterine cervix randomly received at this institute 4600 centigrade in 23 fractions, 45,000 centigrade in 220 fractions, and 5,000 centigrade in 25 fractions, preceded by ICRT, that means fraction being ranging from 1.2 to 1.5 gray per day. HDR application with dose at point A being 800 centigrade, and that was fixed, and 2 fractions were used at a gap of about a week. None of the patients were given chemotherapy in this study. All the cases were untreated prior to the study. External beam radiotherapy was delivered by the Theratron 780 C cobalt teletherapy unit, and intracavitary radiotherapy by HDR microselectron afterloading system using iridium-192 as a radioactive source. The follow-up was done for the clinical manifestations. Histology, the patients were studied according to the age, and the follow-up was done after 2 weeks, 4 weeks, and 8 weeks after the completion of the treatment. Then regarding the statistical analysis, the results were analyzed using descriptive statistics and making comparisons among various groups. Categorical data were summarized as proportions and percentages, while discrete, that is quantitative, as mean, standard deviation. All the associations were tested by using chi-square test. Logistic regression analysis was performed for making model of treatment response outcome with general and clinical profile of patients. Statistical analysis were performed using SPSS version 23.0, including that of Chicago ILUS. A value of P less than 0.05 was considered statistically significant. Now I will continue with the observations in the form of table that we got. That is the general. I'm sorry if the slide is slightly poor and the heading is slightly obscure and the people are unable to see actually what the headline is. So this table shows regarding the general clinical profile of the patients, and the number of patients is 91, as I mentioned earlier. The variable is the age, symptom, histopathological type. You all can see the most common population, that is the age group in this study, belongs to the 51 to 60 years, and it accounts for 41% of the total 91 patients recruited. Then regarding the symptoms and the symptoms, we see in the graph only, that is the most common symptoms that patients attended the OPD was pervaginal bleeding, and that accounted for 60.4% of the total number of patients, that is 91. Then it was followed by white discharge, and further followed by pain in backache and the pain in abdomen, and furthermore burning micturition, and some were the non-specific symptoms. Regarding the histopathological types, squamous cell carcinoma was the most common histopathological type, and it accounted for 84.6% of the total patients' histopathology, and it was followed by adenocarcinoma, which accounted for only 15.4% of the cases. As far as the stage is concerned, the most common stage presented to our OPD was 3B, and it accounted for 70.3% of the total number of patients attending OPD. This is another graph that is depicting you in the form of percentages only regarding the general and the clinical profile of the patients. You all can see that is 51 to 60%. 60 is the major age group that attended the OPD, and Pervaginal bleeding is the most common symptomatology. Histopathological variant, squamous cell is far ahead than the other histopathological types. Only 2 histopathological types have presented in these 91 cases. And the most common stage presented is 3B. Now, the next slide is showing our association of the treatment response with regard to the general and the clinical profile of the patients. Now, the variables are the complete response. CR stands for the complete response, whereas the PR responds for the partial response, right? And going through this entire slide, you can see though that the age group which is having highest complete response, that is about 50% in the age group of 51 to 61. And the partial response is as the age has advances, that is 71 to 80. That means the treatment was a bit failure, very poor in the elderly age, that is beyond 6th or the 7th decade. And symptomatology and the symptoms. Shall I move away? Now, this slide is actually talking about the variables, that is the complete response and the partial response and the p-value with regard to the symptomatology and the histopathological variant as well as the stage. In this chart, we can see that is the complete response is achieved in the squamous cell variant, that is 90%. Whereas the partial response is lower in this category. Then among the symptomatology, the complete response is much better in patients with, it was a backslide, it's 5 discharge. Per vaginal bleeding, the complete response is much ahead, that is 60%. And as far as the stage is concerned, 3B stage is having the complete response in the percentage of 62.9%. No, it's in the range of 95.2%. That means the most susceptible stage for the treatment was actually stage 3B. This you can see in the chart form, that is association of treatment response with variables, complete response and the partial response in regard to the general and the clinical profile of the patients. As far as the age is concerned, 51 to the 60 years age group has shown complete response much ahead than the other age groups. And the symptom, that is pervaginal bleeding, has shown better treatment response in the form of complete response. And histopathology, of course, squamous cell being more radiosensitive, they have shown higher complete response. And as far as the stage is concerned, stage 3B has shown higher treatment response. Now, we have considered, we have done the logistic regression analysis. The logistic regression analysis, and to find out the relationship between the treatment response and outcome with the general and the clinical profile of the patients of 91 in number. Here, it was regarded with regard to, again, this logistic regression analysis was done considering these factors of age, complaints, the histopathological type, and the stage with which the patient presents. And here also you can see that this has been firmly reflected into this, and a variable that is lower beta component is associated with this logistic constraint we have seen. That is, I'll show you in my other slides as well. Yes. Before coming on to the logistic, I'll show you in a slide only how these logistic regression analysis defined a relationship with regard to the risk of partial response or maximum chances of complete response in regard to the minimum beta coefficient in the category of study variables. That were variables were the age group, the histopathological type, the presenting complaint, and the stage the patients presented with. Now, this is the chart which is showing association of toxicities with age. Here also you can see that the toxicity is more with regard to the advancing age. Slide. The most common toxicities that we meet with while we are giving radiation to the pelvic structures, that is, of course, we have diarrhea, we have enteritis, we have proctitis, we have genitourinary cystitis, and complaints related to these organs. Again, you can see the toxicities. The highest toxicity seen was of mild category, that is skin moist desquamation. That is showing the value. You can see these values over here, and it has also been compared with the relation of the presenting complaint of the patient. Now, the toxicities being compared with the histopathological types. In this also, it's been clearly reflected that the squamous cell variant is associated with lower incidences of significant toxicities as compared to the adenocarcinomas. You see that. Now, coming on to the stage. Again, the association reflects that the toxicities, they are, although more in 3B stages, but they can be weighed against the advantage. And it's worth mentioning that none of the cases, they got any serious side effects of radiation, which would encourage for the discontinuation of the treatment. And you can see the toxicity with the response in the form of complete response or the partial response. You can see only the partial response is associated with the higher percentage of toxicity. This is in the chart form. You all can have a look. The complete response and the partial response along with the toxicities. Regarding the conclusion, as you all see, I want to say on this huge platform that wherever there are economic constraints and there are large number of patients suffering from the advanced stage of the diseases, it is very crucial that we should be in a mode of research to find out ways to actually help those patients. At the most, we are not able to give them complete response or the complete treatment. We are not able to actually increase the survival. We can at least do something about to bring down their morbidity, to palliate their symptoms. And at the most, if we can increase their life or survival, that is a boon. So with this study, although the number is small, that is 91 only, recent advances have been incorporated in the brachytherapy, and I know this world is now pursuing linear accelerator, and so many things are coming up. Earlier papers, they were showing about the stereotactic body radiotherapy and things like that, and I'm talking about the basic telecobalt therapy. It feels a bit low, but you see, those people who are already economically constrained, their health budgets are so poor. Don't you think that we can't leave these patients lying to die? We should have some measures at least to help them out. So in this study, if we are using some low resource method to treat at least, and those patients who are coming up to our OPDs with such advanced stages of cervical carcinoma, which is a very common ailment among the female population, then we can still do something about it by this treatment combination of external beam radiotherapy and intracavitary brachytherapy to actually help and have results very close to or equivocal to those that we are receiving today from such higher sophisticated modalities like IMRT and CEP. Thank you, and thank you everyone for listening to me and bearing with me. I'm really thankful to the organizers for giving me this opportunity to present on this platform. Thank you so much.
Thank you, Dr. Taruna, for your excellent presentation. I hope participants
so much.
have learned more.
Ma'am. Thank you so much, ma'am. Thank you very much.
Okay. Does anyone have a question for Dr. Taruna?
Yes, I have a question.
Okay, Dr. Kroos, go ahead.
For survival data, it is better we use a Kaplan-Meier or Cox model instead of logistic regression, because in logistic regression we use when we have complete data. When we have sensor data, such as data collected in cancer for survivals, we use Cox models, Kaplan-Meier, AFT models. I think, but logistic regression we use just for complete data. Thank you.
Thank you, sir, for your valuable inputs.
Do you understand me? We can, for analysis of data, we can use logistic regression and Cox or Kaplan-Meier models. Okay.
Thank you,
but
sir.
when we have complete data, we don't have any censoring. It is better we use survival analysis. Your outcome, I think you have censoring in your outcome. And the majority of survival data like cancers and others, we use survival models. And survival tests like such as Kaplan-Meier, Lagrange, Cox, AFT models. Sometimes the results of logistic regression with Cox regression, they are in agreement, but sometimes they are not in agreements and they are completely different. And the statistician suggests using survival analysis for such data. Thank you.
Thank you, sir.
Somebody else? Okay, thank you, Dr. Taruna. The next